And with my remaining time, which is, give me 5 minutes, I'll just kind of do this one section. It's obesity hypoventilation syndrome with hypercapnia. 63-year-old man with a BMI of 43 visits an outpatient sleep clinic with symptoms of daytime sleepiness and loud snoring that have developed over the last few years. He has not had any hospitalizations in the past year. His Epworth score is 11. Exam reveals that his neck circumference is 43 centimeters and he has trace bilateral pedal edema. He has normal muscle strength. Sleep testing demonstrated an AHI of 65. That's severe. 95% of those were obstructive events. The mean O2 stat is 89%. Spirometry in this individual has an FEV1 FVC ratio that's 80% predictive, which is normal. The FEV1 by itself is 85% predictive, which is normal. The FVC, forced vital capacity, is 82% predictive, which is normal. They do an arterial blood gas, and the pH is 7.4, and the CO2 is 51, and the PO2 is 60, and the bicarb is elevated at 30. This is a compensated respiratory acidosis, chronic respiratory acidosis. So what PAP modality should you recommend for the management? So this is an individual whose BMI is 43. You rule out other causes of hypercapnia. This is someone who has OHS, obesity hypoventilation syndrome, and has severe obstructive sleep apnea. So, and he's hypercapnic. So would you use A, CPAP? Would you use B, ASB? So I'm going to say B sounds wrong because this is not central sleep apnea. You're not trying to stabilize the CO2. There's no role for ASB in these cases. Would you use a BiPAP, spontaneous and time mode? Well, I don't know if I really need a timed mode. This patient doesn't have central sleep apnea. But, I mean, the bilevel is tempting. A BPAP, maybe blow off the CO2. I don't know. Would you use AVAPs, which is that volume assured pressure support? I mean, he is elevated BMI. I mean, you do want to blow off the CO2 a little bit. But would that be the next step right there to go right to AVAPs? Probably not. So it really comes down to, do we use CPAP on these patients or should we use BPAP? And in this case, you know what the right answer is? He has severe obstructive sleep apnea. Got to use CPAP. Definitely. So CPAP is letter A. And I wanted to talk about this. So how do you diagnose obesity hypoventilation syndrome? This is from the American Thoracic Society guidelines. So number one is always your pretest probability, and if they have a high pretest probability, you can go for an arterial blood gas. Ouch, that kind of hurts. And look for a CO2 that's going to be elevated. If you have a low to intermittent probability, you can look at the basic metabolic panel. That's a venous blood draw, and look for an elevated bicarbonate that's going to be greater than 27. And in these individuals, the key thing is that if you have OHS and you have severe OSA, what's going to be driving the hypercapnia is the OSA. So you use CPAP first. If you actually have mild OSA and OHS, then these are the individuals. What's driving the hypercapnia is the obesity, and in those cases, using a bi-level device would be appropriate. But in this patient, AHI was what? It was 65, and he has OHS. Definitely CPAP would be the right answer. I put this slide here to kind of talk about the different phenotypes of OHS. Like I said, that severe OSA, you definitely want to think about doing CPAP first. These are CPAP responders. If they have mild OSA, these are going to be CPAP non-responders. We think about using a bi-level device. So when we talk about how are these individuals hypoventilating, why is the CO2 going to be elevated? It's always multifactorial in general, meaning that some people are hypercapnic because their lungs are very stiff. We see that with some people with neuromuscular diseases. They're having poor gas exchange that can occur, but also maybe you just can't keep the airway open on top of everything else. And that's where maybe CPAP could be helpful in these patients. And I also wanted to talk about chemoreceptor responsiveness. So when we talk about chemoreceptors, everyone, they sense two things: oxygen and carbon dioxide. Where your chemoreceptors are central chemoreceptors in the brain. They sense localized hydrogen ion and dissolved CO2, which is PaCO2, partial pressure of arterial CO2. And there's also what we call peripheral chemoreceptors located where? In the aorta and in the carotid bodies, aortic arch, carotid bodies. They sense CO2 and O2. But the greatest drive to breathe is always going to be CO2. And what happens during REM sleep compared to non-REM, and definitely compared to awake, is that there is decreased chemoreceptor responsiveness when we talk about REM sleep, which is one of the main reasons why you don't get a lot of central sleep apnea in REM sleep. And this is talking about what are going to be my options for using a bi-level device. And my options, if you guys will go down to the bottom, that the blue angle right here is going to be people who have the mild sleep apnea, while the green up here are people with severe sleep apnea, where I would use more of the CPAP. But when I use a bi-level device, I could start off with a BiPAP by itself, or BPAP just with spontaneous. If I feel that they need to initiate, have a backup rate, I use an ST, spontaneous and timed. If I can't achieve my goals with a BiPAP, then I could use something like AVAPs, which is a bi-level device. The inspiratory breaths are volume assured pressure support, where I dial in a tidal volume. And then the EPAP is going to be essentially just talking about the PEEP, which is going to help out with the obstructive apneas. And I put this here because, being a pulmonologist, I couldn't resist to say one thing about COPD. And the reason why there's traffic lights, red, yellow, and green, depends upon the level of evidence that's out there. And I just want to say the strongest level of evidence when we talk about non-invasive positive pressure ventilation and COPD are people who have stable COPD and they're hypercapnic. People who have stable COPD, they're hypercapnic and hypoxic. These are individuals where that have that overlap syndrome, when they get discharged from the hospital, if they're hypercapnic, hypoxic, putting them on the bi-level may decrease the chance of readmission. And this was seen in this study here. This was in JAMA. And this is going to be what happens in individuals during the point of discharge. They were hypercapnic and hypoxic. It decreased the readmission rate, looking at it at 12 months out. And this is why we definitely know that it's important to make the correct diagnosis, have them on bi-level, have them on the right oxygen if necessary, and prevent those readmissions. And with that being said, I didn't think I could be able to talk that much. That was 90 minutes. I hope each and every one of you enjoys this. And more importantly, are you going to use all these pearls to get the best score on your board exams? I can't wait to meet all of you in person one day. And hey, if you enjoyed this, hey, you could listen to my podcast. I have the Dr. Raj podcast for wellness. I have one only just for medical pearls called the Beyond the Pearls podcast. And hey, feel free to say hello to me on my Instagram. I always like meeting people. And I really hope you enjoyed this and have a great night.